My presentation is called 3 out of 5 and the hips don't lie. It's a guide to the SI joint. So I'm glad Mo brought up back pain, because how many times have we seen people with chronic back pain in our clinics, chronic hip pain in our clinics? And most of the time it's in the back, most of the time it's in the hips. And I'm going to disagree with Chubbs on this one, because sometimes there's this joint that we always forget, which is the SI joint. And for the next few minutes, I'm going to tell you about this joint. I'm going to tell you about a good way to be able to differentiate the pain that's coming from the SI joint versus from the back or from the hips. So the SI joint, which is depicted here, is important because it's estimated about 30% of people present with chronic lower back pain actually have SI joint dysfunction. And in certain populations, this prevalence may be as high as 48%. Especially in construction workers. I work in the International Medical Center, and we see a lot of people who do construction work for a living. And like Mo said, we don't want to get unnecessary testing. We don't want to get an MRI on anyone who comes in with back pain, unnecessary referrals and therapies. Okay, but what am I getting at? So one of the things that's interesting about the paper I'm going to be talking about is that this uses a multi-test strategy. So basically, when we think about diagnosis, and we use likelihood ratios. We usually take one test, we plug it into our Pagan's nomogram, and that gives us one post-test probability. Then we do sequential testing, and we do these calculations in our head. Sometimes we get it right, sometimes we don't. What's interesting about this is that they took 5 maneuvers, and they used the strengths and weaknesses of each of these maneuvers to come up with one final estimate. And so basically they're doing the math for us, which is great. So now I'm going to call on Andrew Webster to come up and we'll demonstrate the maneuvers. It's the only time I can actually inflict some pain on him. So if you want to. And I'll show you, for all of those who can't see, I will show you some nice little gifts. So the first maneuver is called the distraction test. So basically what you want to do is you want to identify the iliac crest, you want to cross your arms like this, and you're going to push dorsally and posteriorly, trying to get some traction onto the SI joint. And for any of these 5 maneuvers I'm going to tell you about, if any of these reproduce the patient's pain, that's a positive test. So the first one, distraction. The second one is the compression test. So Andrew, can you flip to your side? And we're going to say that this is the side that's actually hurting because you want that side to be upward. You want to flex their hips at 45 degrees, their knees up to 90, and then you're going to, as if you were doing chest compressions, push down on the hip. And again, trying to get into the SI joint. The third one, and this is the painful one, is the pelvic torsion test. So you want to take the unaffected hip, you want to flex it up a little bit more than 90 degrees. You want to keep it there, and then you want to take the affected knee and push down on the thigh, and that should reproduce the patient's pain. The fourth one is the most well-known, it's the Faber test, and Faber stands for flexion, abduction, and external rotation. So Andrew's a very cooperative patient. You're going to push down onto the knee while holding the contralateral hip in place so that we don't get false negative result, and that should also reproduce the patient's pain. And the fifth one is kind of a mouthful, is the thigh thrust. So you want to flex his hip up to a little bit more beyond 90 degrees. You want to add left the leg a little bit. And you're going to hold the calf and then with your hand, push down. Anterior posterior. Okay, thank you. Okay, so those are the 5 maneuvers. So now how are we going to combine these into something that can actually be helpful in making the diagnosis? So I'm going to tell you about this study. It was done in the Netherlands. It involved 60 patients. And they basically compared these 5 maneuvers with a gold standard, which was injecting the sacroiliac joint with anesthetic, and then a resolution of more than 50% of the pain was considered a positive injection, basically. So this is the really nice ROC curve that they did for their paper, which basically the numbers, on the y-axis you have the sensitivity, on the x-axis the 1 minus specificity, and what you want is really to have the steepest line that you're maximizing both sensitivity and specificity. And the little numbers there are just the number of tests. So we see that about 3 kind of maxes our sensitivity and our specificity. And if we look at the data, we have a sensitivity about 85%, specificity about 79%, with a positive likelihood ratio of 4, and a negative likelihood ratio of 0.19. So if we plug this in to our nomogram where we see 30% is kind of the prevalence that we're thinking about. If we follow this positive likelihood ratio line, it increases our post-test probability to about 65. And if you have 2 positive tests or less, then your probability goes all the way down to 5%. So that's pretty good, but I know what you're thinking. It's like, oh, well, in this study, these tests were already performed by probably experts who do this all the time, so how am I going to be able to reproduce this test? And they actually have studied the inter-observer variation in these tests. And by that I mean, that both people performing the test are actually seeing the same thing. And then you could equate this to this cartoon of Donald Trump in a bowl of mushy oranges and his canaries. And you want to be able to tell the difference, which I can like. And this is the data for that. So over here we have the 5 tests that we performed. The Gainsland test is actually the pelvic torsion test. And over here we have these are prevalence and bias adjusted kappas. The kappa coefficient is just a statistical way to quantify whether what you observe was more than what you expected by chance. What I can tell you is that anything above 0.75 is considered excellent agreement. These 4.6 you can say is moderate agreement, but it's the distraction test. Even though it's a little bit low, I would still recommend doing it. So taking all this together, if you have 3 or more positive tests, then it's most likely in the SI joints, in which case the hips are potentially lying. But next time you're in the clinic and someone asks you, why do you think this guy has SI joint dysfunction, then you can make the transition and be a polyp. And so I just want to thank Dr. Heinrich for her help and Steph, and thank you all for coming and paying attention.